Good evening, everyone, and thank you for joining us tonight. Welcome to Primary Care Response in Aged Care during COVID-19, session number 2. So this is session 2 in our series of 4. So tonight's topic is advanced care planning in times of rapid change. So firstly, my name is Charles Broadfoot. I'm a Professional Development Officer with Hunter New England Central Coast PHN. I'd like to acknowledge the traditional custodians of the lands in which we're meeting tonight, pay my respects to elders past, present and emerging, and welcome our Aboriginal colleagues joining us tonight. So tonight we will be using Slido for questions and for the evaluation poll. So on the right-hand side of your screen, you'll see the questions and the evaluation poll. Alternatively, you can go to slido.com and enter the event code PCR2, so that's PCR for Primary Care Response and the number 2. You'll also see throughout this evening a little QR code pop up on your screen, so you can scan that with your mobile device as well, another way to ask questions. So tonight's session is being recorded, and the recording and slides will be available on our People Bank page, so on the PHN website from tomorrow. So I would now like to hand over to tonight's chair, Dr. Marie Puxty, streaming in from Armidale. So thanks very much, everyone, and over to you, Marie.
So welcome to the second in a series of our 4 Primary Health Network webinars focusing on the primary care COVID response in residential aged care facilities. My name is Mary Puxty. I'm an Armidale-based GP and chair of the Primary Health Network Rural Clinical Council, which is one of 3 clinical councils to the PHN board. I'd like to thank the PHN for asking me to chair this webinar. Hopefully I won't let them down. I'd like to begin by acknowledging the traditional owners of the lands on which we meet this evening, and I would also like to pay my respects to elders past and present. I would like to welcome all participants this evening, particularly representatives from residential aged care facilities, general practice, and our speakers, Dr. Caroline Hullick and Dr. David Healy. Let's hope the IT gods will be with us for the next hour. I think all of us who work in primary care are anxiously aware of the risks of COVID in older Australians. 90% of COVID mortality in New South Wales has been in people aged 70 years and over, and 38% of these people lived in residential aged care facilities. Our priority must be to prevent COVID entering aged care facilities, but also be prepared to respond quickly and effectively if this does occur. The Primary Health Network has developed a COVID response package to support residential aged care facilities, including a capacity tracker to assess workforce need and assist with surge workforce if required, assisting residential aged care facilities in conjunction with the local health district to develop individual aged care facility outbreak management plans, provision of personal protective equipment, telehealth development support, health pathways aged care specific resources, infection control education for clinical staff, and the aged care working group and coordinated multi-service scenario planning, which have initiated desktop outbreak response simulation exercises. These initiatives are excellent, but only if each individual aged care facility acts to make certain they are well prepared. Part of this preparation must include identifying a GP to be part of the COVID outbreak management plan for each facility. We ask each facility represented this evening to reflect that they have fulfilled this requirement of their outbreak management plan. We ask each facility to be sure that they have an appropriate GP involved and to please communicate this information to the Primary Health Network. Another extremely important component of COVID preparedness is advanced care and end-of-life planning. If an outbreak occurs, there will be no opportunity to undertake this process. So we need to be organised in advance to make sure that a dying resident retains dignity and control at the time of their death. Dr. Caroline Hullick is an ED physician at Belmont Hospital who is undertaking research involving the care of older people in emergency departments and residential aged care facilities, and will speak with us about Advanced Care Planning in Times of Rapid Change. Dr. David Healy at Armidale GP was undertaking postgraduate training in palliative care and became involved in the catastrophic COVID outbreak in Newmarch House, where 19 residents sadly died. He will speak with us about his experiences and why end-of-life planning is so important and what can happen when it goes wrong. I'm sure you've noticed that David and I are less than 1.5 metres in distance at the moment, but as David said before, we have known one another for 30 years, so I don't quite know why that makes a difference, but anyway, apparently it does. So apologies for the lack of distance. Carolyn and David will speak with us, and then there will be an opportunity to ask questions on Slido. We also have a list of questions related to advanced care planning from previous webinars that we will try to address this evening. Apologies, I've just been given a note. No, I'm not being given a note. Okay.
I know, I'm upsetting the apple cart already.
Okay.
Already. And we're only, what, 5 minutes in?
I was going to say, we're not going over. So, if it's okay with Charles, I think we'll now pass back to Caroline, who will speak with us about advanced care planning in times of rapid change. Let's see if we can rapidly change this.
Hi everyone, my name is Carolyn Hullick. As Marie mentioned, I'm an emergency physician. I work at Belmont Hospital. I suppose from my perspective, most of my experience is in receiving patients in the ED from aged care facilities who have differing levels of advanced care planning, but almost always arrive on their own with no one to speak on their behalf. So I think when a patient's critically unwell, it's extremely difficult in the ED for us to deliver care that's consistent with the patient's values and wishes without actually knowing what they would want. So that's, I suppose, my interest in advanced care planning, really. I'm going to go through over the next 15 minutes or so just maybe some more of the technical issues around advanced care planning, advanced care plans, advanced care directives, because I think the terminology can all get pretty confusing and it's important to understand. And then we've got some, as Marie mentioned, we've got some time at the end if there's specific questions that need to be covered. So an advanced care planning is actually a process, and it's a process that helps people to plan for their future medical care. It's around discussing their values and beliefs. It's around discussing their wishes and preferences about medical care if they can't make their own decisions. And it's about discussing wishes with their family and other people who they really want to know that what they would want if they were not able to speak for themselves. And it's also about talking with their GPs and other health professionals, particularly in understanding their medical conditions and their likely complications and what's likely to happen over the next period of time. So an advanced care directive, it's important to know that the legislation related to advanced care planning and advanced care directives is related to the state that you live in. So we live in New South Wales, so our legislation is related to New South Wales. So in New South Wales, an advanced care directive is a plan that's written down, but in order for it to be called an advanced care directive, it has to involve the following things. The person has to have capacity to write an advanced care plan, and they must do it voluntarily. It has to be clear and specific about the treatments that they would accept or refuse, and it has to be applicable to the situation which you're in at the time. It often also appoints a substitute decision maker. So an advanced care directive only applies and it can be used in clinical care really when the person doesn't have capacity. The other thing that's interesting to know is that an advanced care plan doesn't need to be witnessed. It's obviously a good idea for them to be witnessed, but they don't need to be witnessed. They can be written by an adult with capacity. It's a legal document, and if someone actually comes to the emergency department with an advanced care directive, we can't override that advanced care directive, nor can their legally appointed guardian. As treating clinicians, there's actually been cases in the Supreme Court where you can be charged with assault if you knowingly treat against the conditions outlined in a valid advanced care directive, similarly to Jehovah's Witnesses and blood transfusions. So everything else besides those things is actually an advanced care plan. So if it's written by the family, if it's written by the person responsible, if it's written by the aged care facility manager, their friend or an enduring guardian, they're all advanced care plans. So capacity is the other important term to understand. So capacity is actually a thing that's specific to the decision that's being made. And a person with cognitive impairment can have capacity. So just having dementia doesn't mean that you don't have capacity. But you need to, it depends on the complexity of the decision that you're making, and a person has capacity if they can understand and retain the information and the consequences relevant to the decision, use that information to make a decision, and then explain the decision and communicate it back to you. So if a person can do those things, and often we use capacity in, for example, in the emergency department, if someone wants to leave and we think it's not a good idea for them to leave, then they're the kind of assessments that we would do. We did an audit at Belmont Hospital looking at advanced care plans, and over the month we had 92 residents from aged care facilities. Only 49% of them came within advanced care plan documentation, but 69% of them had cognitive impairment. Most of the advanced care plans that we did have were really good at describing who the nominated substitute decision maker were. Only 46% talked about medical treatment, and they often say things like not for transfer to hospital, but they're in the emergency department, which makes it quite difficult for us to know what to do next. 17% had end-of-life wishes that were documented in their plans, and only 8% of them talked about values. So why should we have an advanced care directive? So there was a big randomised control trial, I think it was Monash, it's from Melbourne anyway, where they looked at advanced care directives, and they found that really people who have documentation are much more likely to get care at the end of their life that's consistent with their wishes. The patient, not sure, patient satisfied with quality of death is not a very sensible thing to write, really, is it? No, it's about how the family perceive that the patient would be satisfied with the quality of death, and that the family themselves are satisfied with the quality of death. But you can see that people are much more happy that the care is being delivered consistent with what that person would want. So what do older people think about advanced care plans? Again, this is consistent with my experience. Most of the time in the emergency department, they've actually got really clear ideas around what they want at the end of life. And maybe that I'm seeing them in the emergency department during a critical incident that's maybe focusing their answering. But generally, I don't actually see that it's a particularly difficult conversation. But we do know that if they've had a discussion about advanced care planning, they're much less likely to end up in hospital for end-of-life decisions and missions. We know that the patients are really frail and complex, and as I said, high rates of cognitive impairment. And in our local Hunter New England data, aged care facility residents, 40% of them will die within 12 months of an ED visit. And that was across 18,000 patients. We're much more likely to deliver care that's in line with their preferences, and their families and them are less likely to have depression and stress and anxiety related symptoms related to end of life. So they're a good idea. Person responsible, substitute decision maker, these kind of terms get thrown around a lot. I suppose it's important to know that the New South Wales Guardianship Act doesn't use the word next of kin any longer, and then we talk about the person responsible. So a person responsible who's someone is only applicable when that person can't make medical decisions, when the patient can't make medical decisions. They need to be over 18, and they need to agree to be the substitute decision maker, but they can make decisions on that person's behalf. An enduring guardian is actually a legal document in New South Wales detailing the appointment of the person of their choice, and that they can make decisions around medical care, but also lifestyle treatment decisions that they can make if that person loses capacity. Different to a power of attorney, but we're not talking about If you don't have an enduring guardian and you don't have a substitute decision maker, then if you're critically unwell in the emergency department, this is the hierarchy that we use in terms of determining who can make decisions on your behalf. So the first one's obviously the enduring guardian. The second one is a spouse or de facto spouse with whom you have a close relationship and continuing relationship. They're number one. Number two is an unpaid carer, so someone who's providing support to that person on a daily basis before they've entered into care. And if neither of those are available, then it becomes a relative or friend. I think often people think that their children would automatically be making decisions on their behalf, but unless they've appointed, as you can see, they're quite a long way down the list. So what do you need to know, I suppose, as a GP or a clinician about advanced care planning? People can change their mind, and families often do with advanced care plans. If a plan exists, then previous conversations I suppose when I see the patient in the ED, if there's an advanced care plan that says not to be transferred to the hospital and they're in the emergency department, I think that's okay, because at least I know that they've talked about it before and we can talk about it again. And I think the good thing about planning, as I said, it's an ongoing process, so we can continue to have conversations about what they would actually want. And obviously coming to the emergency department and being admitted to hospital is an important trigger, but there's others as well. Sometimes when people are doing their enduring guardian documents, if family and friends are concerned about the person deteriorating, if they've got serious illness, I suppose they're all triggers to think about writing an advanced care plan. And I think the other thing that's actually really important to know, and I'm not sure that we do this well all the time for residents of aged care facility, it's actually really important that we had the right conversation with the right person. And often that doesn't happen. It might be the person that's rung on the phone that day rather than necessarily the person who's been appointed. So I think it's important to go back to that. So what do we also need to know? Doctors can't be forced to provide treatment that we consider futile by our peers. So just because it says that a person wants CPR or they want to be intubated or they want to go to ICU, we're not actually forced to do that. Symptom management, comfort measures, palliative care is appropriate treatment and isn't withdrawing care. And I think often, again, in hospitals, we've got a bit of a tendency to talk about withdrawing care, and it's in fact the wrong terminology. And sometimes antibiotics and other limited treatments can be part of symptom management and part of end-of-life care, but again, another area to talk about. Advanced care plans include any or none of all of the available treatment options. And I think from my perspective, the most important thing is thinking about that person's goals of care. What do they actually want? So when a person comes to hospital, we actually fill out this form on the right, which is called an adult resuscitation plan. So we use the advanced care plans and the advanced care directive and the documentation that we receive from the aged care facility, and we fill out this form, so a separate process. And if someone hasn't got any of that documentation, we're still meant to fill it out anyway. Why are we worried about it? I think we forget how frail people are who are from aged care facilities. And this is a review article, but you can see the differences in hospital-acquired complications for someone from an aged care facility versus an older person living in the community. So someone in the community, 4.3% pressure injuries, aged care facility 19%, delirium 8% from the community, 38% from an aged care facility, invasive procedures, we do that to lots of people, but 49% in the community, 72% if you're from an aged care facility, 3 times more likely to get hospital-acquired pneumonia. And then the data below that is the ACE data, but you can see about 7% of people from aged care facilities die when they come to a Hunter New England hospital, and they die during that admission. But interestingly for me, 33% of them die within the first 24 hours. So I think there's some work that we can do on advanced care planning and futile care, in that if someone's dying within the first 24 hours, unless they've got really difficult symptoms that are hard to manage, I would suggest that perhaps they could have stayed in the aged care facility if they could get the right support. And as I said earlier, if you come to a Hunter New England emergency department and you're from an aged care facility, then 41% of those people will have died over the next 12 months. So it's a pretty high mortality, not related to the ED, of course. Goals of care. I think for ED, some of the work that we've been doing with ACE has been around determining what the goals of care are. What's the purpose of the transfer for the patient from the emergency department? And I think you can divide it up into different phases of care that's worth thinking about. So I suppose if you're fit and healthy and you've got an injury, then it's a curative model. Restorative is, I think, lots of our heart failure, kidney failure, respiratory failure patients that we see. Palliative is symptom management, and terminal care is end-of-life care. And if you think about residents in aged care facilities, most of them are actually in the palliative, some restorative, but a lot of them are in the palliative phase of their life. And we should maybe be thinking more in that term. But I think from an ED perspective, as I said earlier, they arrive on their own. They arrive sometimes or often unable to communicate with why they're there. And the junior doctors can see a really frail, complex patient on 15 or 20 medications, and then they've got to try and work out what's the reason for this transfer. So for us, determining that purpose was actually one of the most important parts of our ACE program, because we need to know what you need us to address. If you want us to just address the sore wrist, then please say that. As part of COVID, and probably what we need to do into the future, we've been looking at what kind of objective markers can we use to think about mortality and morbidity of critically unwell patients in the emergency department. And our college is promoting the use of the clinical frailty scale. I actually really like it because it's quite straightforward and you don't have to calculate anything, and tells you pretty much what level of frailty is when you look at the definitions. But if you look at that, really most people who are living in an aged care facility, by the mere nature of the fact that they're in an aged care facility, have already got a score of 7, so they're severely frail. And then there's very severely frail and terminally frail. Why is that important? So this is not related to COVID, but it's outcomes related to hospitalisations in the NHS. It's English research. But basically you can see that if you've got a frailty score of 7, then 11% of people will die in hospital. If you've got a score of 9, then 31% of people will die. And as I said earlier, it's thinking about palliative versus restorative care, thinking about transitions of care, thinking about what we can do to make this person comfortable, rather than necessarily treatment that's going to cure their dementia. This is the health pathways that we've talked about before. I've been working pretty heavily over the last 6 months, and big thank you to the PHN on developing the COVID pathways, and I would encourage you to look at them. And each of the blue points is a hyperlink to further information around advanced care planning, but there's also things on medications, treatment and assessment of COVID patients. And these are some of the resources that I've talked about. That's the top one's the Clinical Frailty Scale website. There's actually an app on your phone. If you just go to the App Store and put in CFS, it comes up, and you can actually just use the scale, and we use it pretty regularly in the ED. End-of-life directions for aged care is an online course that you can do that's actually pretty quick. That one's aimed for aged care facility staff. Capacity Australia's got some really important information around capacity assessment, which is an extremely complex topic. Advanced Care Planning Australia, you can actually look at different states, and if you're living in Queensland or Tasmania, you can actually look at the specific legislation and information related to that state. And then End-of-Life Law for Clinicians is the one I'd probably most encourage you all to look at. It's designed for general practitioners and specialists, like emergency physicians like me, and it's really simple. There's about 10 modules. They don't take very long, and it goes through all the law related to end-of-life care. So thank you, everyone. That was the end of my presentation.
Thank you very much, Caroline. That was fantastic. We already have some questions on Slido, so we'll get to those in a minute. But first, I'll hand over to my extremely close colleague, David Healy.
Thank you very much, Marie. I'll just give a little introduction about myself. I'm a general practitioner in Armidale. I've been a general practitioner for 30 years, and I have an interest in palliative medicine and aged care medicine. And this year I decided to do the clinical diploma in palliative medicine, and I became an advanced trainee placed at Nepean Hospital from the beginning of February to the beginning of August this year. So this is how I came to be involved with Newmarch House, and I'll give the link in a minute. What I'm about to give you is information about what happened at Newmarch House that's based on my own experience, plus the report that our palliative care service has provided, plus the report, the official government report by Lynn Gilbert and Alan Lilly that came out in late August, plus the New South Wales Health response to that report, plus media statements by the Chief Executive Officer of Anglicare, Glenn Dard, that he was quoted extensively in the newspapers at the time. I want to make it clear that I'm just making observations about what happened. In no way am I apportioning any blame to any service or any person. And these observations are provided to promote learning, and particularly with New South Wales, Newmarch House has become the touch point about what went wrong and what we can do right. To give you some background, Newmarch House is a 102-bed facility, opened in 2012, so quite a modern facility. It consisted of 3 separate wings, and it was situated, and it is situated 2 kilometres from Nepean Hospital. It was run by Anglicare. The first case of COVID was identified in a staff member on the 11th of April this year, and that was Easter Saturday, and therein became the first problem. Lockdown occurred on the 12th of April, which was Easter Sunday. By the 16th of April, there had been 15 cases identified in staff and residents, and by the 26th of April, so 15 days after the first case, there were 52 cases identified in staff and residents. No new cases developed in residents after the 30th of April, but new cases amongst staff occurred till the end of May. All up, 34 staff became COVID positive, and 37 residents became COVID positive, and 19 of those residents died. The outbreak was officially over on the 15th of June, which means it was just more than 2 weeks after the last case had been identified. Now, Newmarch House had prepared for an outbreak. All the nursing homes had been sent information by the Commonwealth Government throughout February, and Newmarch House felt that it had coverage for staff layoff of 30 to 40% and enough PPE and line of supplies for their personal protective equipment. I should also point out there had been an earlier outbreak at the Dorothy Henderson Lodge in the inner west of Sydney. There, within 24 hours, the facility had engaged 2 infectious diseases and infectious control specialists and had sent the majority of their affected residents to hospital. In that case, they had 16 positive cases, of which 13 were admitted to hospital right from the time that they were originally diagnosed. Of those 16 cases, 6 died. So what happened at Newmarch House? When news broke that the index case had occurred, within the first week, the loss of staff was very high. And in fact, 87% of staff went missing in that first week, either because they were close contacts of the affected staff members, or simply did not turn up for shifts. So there was a high rate of absenteeism. So the first problem was difficulties in getting staff, and the CEO, Grant Millard, has outlined in public comments that that was one of the big problems in the initial days. The second one was the supply chain for their PPE broke down. He said that the lines of supply that they thought they had lined up just evaporated, and management was getting conflicting advice from the state agencies and the Commonwealth agencies about how to use PPE. In the end, they decided to go with the state agency, which was the infectious diseases staff at the Nepean Hospital, who advised that everyone in the facility wear PPE at all times. The Commonwealth government was advising that people should only wear PPE for positive and suspected cases, which meant that there were some staff in the facility not wearing PPE for some of the time, and that's one of the that became one of the problems. Third issue was that the management structure for Newmarch House within the Anglicare fell apart. The New South Wales health documents outlined that they could not get a response from senior management of Anglicare for 48 hours after the first index case had been identified. Remember, it was the Easter long weekend, so but still, New South Wales Health have said that. Our service, when we went to provide a service, found that there wasn't a system. Anglicare had really no idea how to incorporate a state service into their facility. And we had a lot of trouble actually getting into Newmarch House to provide palliative care advice. And in the end, we just tagged along with the geriatricians because they seem to understand geriatricians, but not palliative care physicians. And if you consider that aged care facilities are Commonwealth-funded institutions, and they deal with a range of Commonwealth-funded agencies, they might know of the local hospital, they might know patients who might see doctors from hospitals or come back from the emergency department from hospitals, but they were very unfamiliar with the distinct agencies that hospitals can provide. Likewise, the Nepean Hospital, and I think this is probably a generalisation for hospitals generally, had no concept of how aged care facilities are run. For a lot of people, they think aged care facilities are hospitals and run like a hospital. But as anyone that works in aged care facilities know, that is far from the truth. And aged care facilities promote themselves as providing a homely environment and try and have personal effects for the residents and try and limit a clinical sort of outlook within the facility. We also found with the management structure at Newmarch that it was very unclear as to who did what. And this became some of the problems with who communicated with family, whose job was it to try and organise staff, whose job was it to communicate with the health authorities. In the early days, it was all left to the person in charge in the facility at the time, and that is much too high an expectation for that person to give. As I mentioned before, the lack of staff was a big issue, and the CEO said that they had a lot of trouble with the registered agencies of trying to obtain staff. Agencies found that when they offered staff a job and they said, where? Newmarch House, oh no, not going there. So there was a lot of pushback from people willing to even go in from the agency side of things. Now, one of the aspects that was discussed in the official government report on the new March House was the decision to make the residents hospital in the home residents within the facility. I will say that those of us in Nepean Hospital, we felt that that was a controversial decision at the time. To give you some background, Nepean Hospital had an existing hospital in the home process, and at that stage, there had already been community presentations to the ED of patients with COVID, and if they were deemed not needing hospital admission on clinical grounds, then they were sent home and admitted under the hospital in the home system. They were provided with means of taking their temperature, taking their pulse oximetry, taking their blood pressure and pulse, and would have someone phone in each day, how are you feeling, that sort of thing. And that model worked well for people in their own homes, where you may have 1, 2, 3 people that needed to isolate within their own home environment, and follow-up was fairly straightforward. So the decision was made that we could replicate that model within the New March Aged Care facility, and the official report indicated that that was probably a flawed decision. New March House thought, or the management of Anglicare thought, that since people were hospital in the home residence, that nursing staff would come from the Nepean Hospital to manage these residents within the aged care facility. This is where the lack of understanding, because really the hospital and the home was only going to provide a consultative service, but it was up for the existing staff on the ground provided by Anglicare to do the work at the recommendations of these consultative service. Our service found that much time was wasted trying to understand what was happening on the surface and who was doing what. Another issue became communication. There was a lack of clear hierarchy, and meant that there was no control over the messaging. And as anyone that has dealt with families generally, you're never going to control families. And a lot of our time as a palliative care service was spent talking to families and providing sort of information from, New March to residents, particularly on the patients that we were palliating. There was no system within Anglicare to have a person who became the sort of communication with the media and communication with the families, and we actually recommended that facilities need to identify someone who is just communicating with the media and the authorities, and someone whose job it was to communicate with the family, and to have a system so that that can be covered 24 hours a day. For the general practitioners, so one of the things was that New March House came under the health orders of the New South Wales government, and so it went into lockdown. That meant that the GPs could not go in to attend their patients. They were locked out. Some GPs had banded together to offer a link as a communication representative between the patient and the family. New March House had a system where they used electronic records, and GPs who had residents in the facility could access those records remotely. But because the facility had to get in staff who were unfamiliar with the record system that was used, they resorted to paper-based systems. So suddenly all the writing within the facility was paper-based, and there was no way that anyone externally could get access to those notes. And like I said, with the communication, there was no one charged with giving that communication out to family or media. The other problem that it became was for those non-COVID residents. So you've got 37 residents who became positive, that still left 65 residents who were not positive, and they were suddenly left without care. And it took a few weeks, but Anglicare did get some doctors actually into the facility. But those doctors were fairly junior doctors, and I spent a fair bit of time answering phone calls about clinical matters for the non-COVID residents, because I found out that there was an experienced GP at Nepean Hospital that could answer these questions and answer his phone. So that was, so the poor GP could not do anything for their residents. The residents who didn't have COVID, their health needs were not met within the facility. It took quite a while for the system. In fact, it took about 3 weeks, and they actually got a change of management team. They got a management team in from Baptist Care that had the experience at Dorothy Henderson Lodge to sort of oversee the management within Newmarch House. Those first 3 weeks, the CEO described as chaotic, that it was just absolutely difficult. In terms of the staff trying to use PPE, once it was decided that staff should just don the PPE and wear it all day on their shift, and then go to a separate area to take off the PPE so it could be disposed of, so they could then have the appropriate wash afterwards. Up until that point, it was take it on, take it off, depending upon whether they were dealing with a suspected or at-risk patient, because that had been the advice from the Commonwealth Government. Just some other points about Newmarch House. In terms of palliating Newmarch House, we found that the symptoms of COVID-19 were actually quite minimal. We, I think, had sort of been aware of the images that came out of, for example, northern Italy, of these patients with severe respiratory distress. We found that that wasn't the case. We found that fatigue was the primary symptom. We found that the patients just simply became less and less responsive, more and more tired, their oral intake went down, that sort of thing. And the use of medication was fairly standard in terms of the dosages that we use. So there wasn't a huge amount of dosage of high amounts of sedatives or opioids to manage respiratory symptoms. And that led to one situation that was reported in the official report. So at the outbreak, we had worked out with the Nepean Pharmacy packs that could be accessed after hours by the facility, ringing the appropriate nurse unit manager and then sending the packs to the Newmarch House. We also sent some extra packs, thinking there was going to be a high need for the palliative medicines. In fact, we gave Newmarch House so many opioids that they couldn't store it properly. We had too much opioids for them to store safely and legally, and that was actually something that we did not realise at the time. The advanced care directives, that was one of the justifications for using hospital in the home, as the majority of patients had a MOLS that indicated that they wanted their care, if they became unwell, to continue in the aged care facility. Our service had recognised that crucially, the question had not been asked, what do you want to happen in a pandemic? What do you want to happen if COVID was identified in your facility? What was important to you and what's important for your family members if the facility was to go into lockdown? So the questions over the use of New South Wales health directives, the use of things where facilities could go into lockdown, where family members had limited access to visit their loved ones, the fact that you might be in a wing of a facility where there are some other COVID patients. How do you feel? How does the family feel about you remaining in that setting, even if you test negative for COVID? So these are some of the questions that were not discussed with the residents before the facility went into lockdown. But like I said, it was one of the justifications for utilising hospital in the home. And the official report has sort of recommended that we need to go back and specifically ask the resident or their persons responsible the COVID questions in terms of what do you want to happen if COVID is identified within the facility. The last thing I just want to mention is that it is always important as clinicians to have some aspect of self-care. And our team faced a bit of moral distress in not being able to provide the kind of care we wanted to provide. In the end, we provided telehealth services on a Monday, Wednesday and Friday, and could plan visits on a Tuesday and Thursday, but that was limited to 2 members of our team. And when you're dealing in a palliative situation, communication is probably our most important tool. And the way that we had to adjust and manage this situation proved to be challenging and did become distressing, particularly for our consultant as the head of the team. I think I will end it there, and I'm very happy to answer questions in relation to Newmarch House. In terms of what facilities need to do for the future, I think the documents have come out since then and based upon that experience. And I know that in a discussion that we had earlier with the Hunter New England Health Service and amongst the aged care facilities up here, is that if there is a positive COVID diagnosis within a resident, that for infection control purposes, it is probably better to strongly recommend that the person be admitted to a hospital from the get-go. But like I said, I'll end it there and happy to answer questions later on.
Thank you very much, David, for your cautionary tale that we need to make sure it doesn't occur again. And that's really what this webinar and series of webinars are about. So we have quite a few questions on Slido. I might start not at the top at the moment, but
Yeah. Hi Marie, it's Carolyn speaking. We're having some audio issues. We can only hear David, we can't hear you now. I'm not sure why. Oh, no.
sorry, is the audio okay now?
No.
no. Okay. Yes, it's working. Hooray! So please confirm that if you wouldn't mind with another typed message, and I'll start again. So again, thank you very much, David, for what is a truly cautionary tale. And we need to work together, and I think that's the important part, to make sure that this does not occur again. So we have a few questions, and we have about 10 minutes left. So the first question I'm actually going to pass to Caroline, if that's okay. Someone who is anonymous in the audience has asked, what is MOLST? MOLST. Could you explain to us what that acronym means?
I think David mentioned the MOLST as well. So in Hunter, New England, it's pretty common for patients from aged care facilities to have stands for Medical Order for Life-Sustaining Treatment, and it's the form, I suppose, that gets used as an advanced care plan form pretty regularly, particularly in Newcastle. I'm not sure about Armidale, but that's what it stands for. So it's a form of advanced care plan.
It's fairly limited document because it really just gives basically 4 choices, like, do you want to go to hospital? And if you want to go to hospital, do you want to have intensive care and CPR, or do you just want ward-based care, or do you want treatment just in the facility and that sort of thing? So I don't know, is that seen in the emergency department as giving clarity about what sorts of treatment patients want when they turn up there?
Okay, we might, another question for Caroline, if you don't mind. Again, from Anonymous. Why do you think only 49% of advanced care plans came to hospital when residential aged care facility residents believe that most people have an advanced care plan in the facility? Was it that they just were not sent? So was it an admin stroke paperwork error? Any ideas?
It could be all of the above, and as David referred to, the ones that do come often say not for hospital rather than anything more specific around what they do want in hospital. But I think the problem is where it's a really important document that's requiring humans in order to get it from the patient, the family, where it's been written in the aged care facility and then transferred to the emergency department. And there's a lot of hands along the way. The aged care facility staff, the ambulance staff, the ED admin staff, and clerical, medical, nursing staff. So I think the 49% probably reflects some of it going missing. I know that My Health Record now has the capacity to upload advanced care plans and advanced care directives, but I think we do need and we can see My Health Record it's pretty straightforward to see My Health Record in the emergency department. I'm not sure that that's necessarily the right solution, but we do need a really concrete solution in order for advanced care plans to make it to the ED. But I think it's a lot of different reasons.
Yeah, thank you very much, Caroline. That's actually a really useful sort of suggestion that as GPs we could probably put advanced care plans onto the My Health Record. It's not an impossible task at all. We just need to think about it, I think. Another question, again, probably for Caroline. Sometimes a person will have 2 people or more as enduring guardians. Sometimes people don't agree. How do you determine what happens in these situations?
Yeah, it is interesting, isn't it? Sometimes when there's conflict in the family is the time when there are more than one enduring guardian. I suppose the way we deal with it is, one, making sure that we've got the right people in the room, and then having ongoing conversations around what's required. And I think really the medical decision making still sits with the medical staff, doesn't it? We're not required to provide care that's futile. And it's bringing the family around to understanding the right course of action. And I suppose from the family perspective, I often take it back to them and say, well, what would your mother want if she was able to speak for herself? I said, I'm hearing that you both want different things, but it's actually not about what you want. It's actually about what your mum would like in this situation. And sometimes that helps to bring it back to the moment in time rather than the mother that they wanted from 5 years ago, which is actually not possible.
Caroline, one last question for you, and then I've got a few for David, if that's okay. How do you frame comfort care versus active treatment with families?
Oh, what was that question? Could you repeat that again for me, Marie?
Absolutely. How do you frame comfort care versus active treatment with families?
I don't think I necessarily use the words. So I suppose it's around defining what the problems are that we see in front of us and understanding what the person would want if they were in the situation. And often patients, even if they're having active treatment, which is not a word that I would use, they still need palliative comfort symptom management anyway. So often it's a combination of the two things, and it's not necessarily a kind of cut and dried thing. So, like COPD is a really good example. Patients with significant distress from their breathlessness in the emergency department who have respiratory failure and might get BiPAP, we would still often give them small doses of morphine to help to alleviate the situation anyway. So I don't know that we necessarily need to be being really concrete around the differences between the two. Often what I talk about with the family is these, this is what we've found, these are the issues, and these are the things we've agreed to. And things like antibiotics, you might say to them, well, we can try the antibiotics for the next 24 hours, but we'll see how they are tomorrow, and then we can make more decisions around what should happen. I think one of the challenges, as I said, in ED is the person who's actively dying when they arrive. And in a lot of circumstances, I try and send patients back to the aged care facility if I think that that's what they would want and their family would want. But if someone's probably going to die in the next few hours, then sending them back in an ambulance back to the aged care facility is actually not a very thoughtful thing to do.
Thank you very much, Caroline. I have a few questions for David. First of all, I just wanted to let you know that Jodie Carey says, thank you, Dr. Healy, we miss you on Tyree. Which is lovely. Okay.
Thank you, Jodie.
Secondly, do you think we should call aged care facilities hospices instead?
Well, that's actually a very interesting philosophical question, because nursing homes have become de facto hospices anyway, because the decline of palliative care hospices as being used as hospices, in other words, caring for the dying person. Often hospices are seen as managing symptoms, and the patient are there for a short period of time and then they're moved elsewhere. So a lot of patients have been moved into nursing home for their end-of-life care. So I suppose that's a very interesting philosophical question, and it is a much simpler word than residential aged care facilities. So, perhaps we should try and make that change.
There's a question from Kate Miller. What can facilities or managing companies do to ensure that this does not happen again, in reference to Newmarch House?
I think the report from to the state government by Lynn Gilbert and Alan Lilly specified that facilities need to form a management team, a COVID management team, and a person on that team must be a general practitioner who is to assume sort of the clinical lead. And they need to utilise the documentation, such as we mentioned at the outset from the Primary Health Network, about what to do. So it is all about, the primary aim is, as you mentioned at the beginning, Marie, not to let COVID in the facility. So the first thing is to be very strict about letting people into the facility, having one entry point, having people sign in and sign out, temperature taken, those sorts of things. The second thing is that if there is a resident who has the sniffles, then that resident needs to be immediately isolated, immediately COVID swabbed, and the facility must know how to utilise PPE for that resident from the get-go until the COVID swab comes back. And if there's 2 residents in a facility who have upper respiratory symptoms, then the facility must notify their local public health network that is what's happening. Even they're not to wait till the COVID swabs come back. They're to let the facility know that they've got these residents and they've done the swabs, so that the public health facility can be forewarned and can get into act if there is a COVID positive case.
Thank you very much. I'm afraid I'm getting silent. We do still have a few more questions. So what we will do is try and obtain written answers to all of the questions, plus the previous questions that have been asked, and circulate those to anyone who's attending this evening. Can I particularly thank Dr. Caroline Hollick and Dr. David Healy for extremely interesting and both disturbing presentations. I'd like to let everyone know that the next Primary Health Network webinar in this series will be on infection control and PPE in residential aged care facilities, and that's on Tuesday, the 1st of December at 6:30 p.m. So again, thank you to the PHN for hosting the webinar. Apologies if we had some audio issues during things. We're sort of literally flying by the seat of our extremely close pants at the moment. And I would like to thank everybody for attending. Thank you.
Thank you so much, Marie and David. Thanks everyone for sticking with us. Apologies, there's been a few audio issues during that panel discussion. Not to worry though, we're collating all of your questions and we've already started putting some responses together. So we'll have a look at all of those in the next day or two and we'll get those responses. We can pop that up on our People Bank page so you can have a look at that resource as well. But thank you for sending in questions for our panellists tonight. So I just want to take the opportunity to thank Dr. Puxty, Dr. Healy and Dr. Halleck for generously giving your time tonight to share your knowledge and your insight. It's been great. Thank you for coming along. So thank you all for attending tonight. So as Marie mentioned, this is the second session in a series of 4. So the next session is on PPE and infection control, specific to residential aged care facilities. And we've got this in the calendar for Tuesday, the 1st of December. So keep an eye out for that one. If we could just ask you to please fill out the evaluation poll on Slido. We really value your feedback. And yes, that would be great because we love to improve on the information that we can give to you and keep it interesting and relevant to your practice. All right, well, thank you again, everyone, for joining, and we'll wrap it up there. So have a safe evening and we'll see you next time.